Okay, we're going to wait just a couple seconds more while everybody gets transferred in from the phone line or from the waiting room online. But for those of you coming in, I just want to welcome you on behalf of Vibrant to the next installment in our Vibrant Integrative Educational Webinar Series, or VIEW. Today we have Dr. Brandon Brock back to educate us all on the Neural Zoomer Plus and all of its glory. I think this has been a very long-awaited training or webinar. Dr. Brock, I know people are incredibly interested in this test and all it has to offer. So, you know, Dr. Brock has done a webinar for us before, so some of you may be familiar with him. You know, just a little bit that you need to know about him is, you know, he basically specializes in chiropractic neurology, if that is the correct term. Dr. Brock, is that how you would describe this? But it's so much more. Is that correct?
There's so many words to describe me.
There's a lot of letters.
That's one of them, sure.
Lots of letters there. His specialties are in functional neurology, and he has done a significant amount of research and training clinically in this field. And I think that as he walks through what the test is about, what it can be used for, and then the functional applications of this test, you're really going to find that his knowledge is so profound as far as how deeply we can get into this. So today is going to be sort of a intro to this, and the upcoming, we'll have some additional training resources that we'll talk about towards the end of the webinar. But I will turn it over to you, Dr. Brock, because I want to make sure that you have as much time as possible, because I know you have a lot to get through tonight. So thanks so much for joining us.
Well, thank you so much. And it is a super pleasure to be here. This test is one of those things that myself and a bunch of other people really in the functional neurology world, we were kind of dreaming of, because, I mean, we love functional medicine, we love functional neurology, some of us love medication. This test, it covers so many boundaries, and it just does so much stuff. And so we were really cool, and we were really just absolutely stoked whenever we said, look, we want these markers because we feel like these markers are getting in the way of either A, an appropriate diagnosis, B, some sort of functional therapeutic modality, like what would functional neurology would do, or even a functional medicine modality, or, believe it or not, a medication. So we spoke, and Vibrant listened. And I think that that is one of the coolest things that a company could ever do, and that is listen to their practitioners. I know a lot of you, I don't know all of you, and I don't even know who all's listening, but first of all, I'm glad you're here. I'll try to make this as educational and give you as many nuggets as I can. The way this is going to work is I'm just going to glance over the Neural Zoomer Plus. And when I say plus, this is sort of the second generation of the test. And what I'm going to do is I'm going to go through the categories and what they mean and how important they are to us as clinicians. And then I will follow up subsequently with each section and break it down, and I will go through, okay, here's the blood-brain barrier. Here's what these markers really mean. Let's break them down, dissect them, tell you exactly what each little marker means, and then what is the nutrition, what is the medication, what is the environmental component, what is the nutritional component, what is the lifestyle component. So right now is me just giving you the overview, and then on the follow-ups, I'll give you the breakdown of each individual one. And by the time you go through the whole series, you'll be able to use this test. Now, here's the thing. A lot of people go, this is just one test. And my answer is, you're exactly right. This is one test. I love labs. And I will tell you that Vibrant now has an amazing, like, mold inhalant panel. They have an amazing Lyme panel. They have great gastrointestinal panels, so you can determine if there's inflammation coming from there. Infectious disease panels. At the very end of this, I have all the different panels that would plug into this, where you might have a trigger that turns into inflammation, that turns into autoimmunity, that turns into neurological symptoms. And by the way, when I break down each section as we go, I will tell you the clinical findings to look for. Because just because you have an antibody does not mean you have full-fledged autoimmune disease. Some people have silent antibodies, but if they get unhealthy, and I've got a slide over this here in a minute, if they get unhealthy and they get inflamed and they start making things like Th17 and it starts changing the nucleus and the production of pro-inflammatory cytokines and antigen presenting cells start kind of kicking up, then you can turn from a silent autoimmune disease into something like full-fledged autoimmune pathology as it eats or destroys tissue. So I think one of the things I did in this is I put in, and I think one of the things that is really cool about this company is I talk about their lab, but then I talk about the other things that I do that makes this lab come to life. And this is what so many people have had a problem with. They're like, look, this is great information, but I don't understand neurology. It's scary. I want to take the fear out of you. And then there's so many people like, I find these markers, I don't know what they mean. I don't know how to clinically look at them. I want to give you clinical signs and symptoms for each one so that you can determine if it's truly being expressed clinically or if it isn't. So if we can do all that stuff over the course of the next 3, 4, 5, 6 months, you'll be able to order this test, have treatment paradigms, know when to refer out, not to refer out, and use this test in a way that will be beneficial for you. So I think that that's kind of the goal of what we're doing here. So anyway, this is NeuroZoomer Plus. Vibrant has been very good with working with clinicians, not just one, not just two, not just three, not just four, but lots of them. And taking a consensus of the information. What do the clinicians want? And I'm one of them. I can just say that I'm one of them. I'm very, very fortunate to get to be here. I can tell you that I have lots and lots and lots of mentors. I am just a culmination of a bunch of different practitioners that are all very, 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 very talented. Too many to name. Many of you know them. I have much love for them. That's all I want to say, and nothing bad to say. So just real quick about myself, I practice in Dallas, Texas. I'm getting ready to open up a new family practice. I do work in orthopedics. I am doing a fellowship in stem cells. I am starting a PhD. I do have a doctorate in nursing practice from Duke. I'm a global clinical research scholar from Harvard, so I like to do secondary analysis and survey design. And I'm also board certified in integrative medicine and have a diplomate in neurology, nutrition, conventional medicine, integrative medicine, and I'm a fellow with the International College of Chiropractors. And I will say this, I love chiropractic. I think it's fantastic. I love integrative medicine. I think it's fantastic. I love functional neurology. I love medicine. So no matter what degree you have, I'm going to try to plug this in. So here's the rules. If I talk about a medication and you're a chiropractor, please don't get angry. And if you're a medical practitioner, I talk about a nutrient, please don't get angry. This is just us simply running through this and talking about how it applies to every single provider. Okay, here's me, no big deal. All right, so there's a lot of different things going on in the world of testing. And I want to say this, there's a lot of good labs. You're not going to hear me say anything bad about any of these labs. The only thing you're going to hear me say is this. A lot of the top labs are, they will all argue their sensitivity and specificity, meaning they're reliable, okay? And I think that that's great. But what we have to talk about is, do you have the technology to be realistically priced? Thing right out of the gate. What is the number one thing that is the problem with seeing chronically ill patients? And that is this, the price. Here's the thing. You're a great clinician. You want to do amazing things. You want to use supplements or functional neurology or medication or whatever it is that you do, but you know that you have either $800 or $900 of testing to do to figure out where you're at, or you have $3,000 or $4,000 or $5,000 of testing to do. The technology that Vibrant has allows us to do antibody antigen autoimmunity testing to where it is not as laborsome, it is more computerized, it is more mechanized, it is more sensitive, it is more specific, and it is faster to do. So when you say that, it's cheaper. It doesn't take as much man-hour, okay? It's not to say that ELISA testing is bad or that Western blot testing is bad or immunohistochemistry is bad or even flow cytometry. There's times where I love flow cytometry tests. But the bottom line is we have technology now that is actually going listen, medicine has to have technology that allows us to do more tests at a faster speed for less money. It's the bottom line. It's how we make a living, and we have to make a living. And I'm not a practice management guru, but I will tell you, we have to make a living. We have to be able to offer these tests, and not each one costs $1,000. So it's important to me to be able to do that for my patients. And then there's one final thing. I don't want to wait 3 weeks for my tests anymore. I'm a little fired up. And it's because I don't want to wait 3 weeks for my tests anymore. And I don't want to be told, basically, I have to wait. It doesn't matter. You're going to wait. I want to be able to get these tests done a little bit faster. And I will tell you that Vibrant has done that for me. So here's what they've done for me. They've made the test faster. They made the test cheaper, and they're more sensitive, and they're more specific, and they published white papers for their norms. So all of that matters. And when we talk about this, the technology makes the difference. The technology really hasn't made its way out yet. If you look at this right here, I look at the 3D dense technology, or the actual wafers that Vibrant uses. And some of the things that are happening here, if you look, it's more scalable, and it gives a significant cost reduction because it's not as laborsome. You can do more tests on one wafer than you can in an ELISA well, and it doesn't take as many man hours. And not only that, the density of the molecules per site improve the analytical sensitivity and specificity. So I need to know that my data is accurate. Now, the only reason why I'm telling you this is because a lot of people don't understand this stuff. They're like, what's ELISA technology? What is your technology? What is the computerized technology? I'm just telling you this. We'll make it simple. We have good sensitivity, good specificity. We have a good coefficient of variation, which I'll show you in a second, which means this: is this reliable or not? And we can do all kinds of things like replicating peptides, and I'll show you on some of these slides. So this is ELISA, and this is what most people are using. And I wanted to talk about this because I've used ELISA tests for years, and there's absolutely nothing wrong with it. It has really good sensitivity and specificity, but some of the problems is some of their antigens are not in their native forms. You get some false negatives, and you get some false positives because there is some heterophile antibodies that are produced here. And not only that, it is very time consuming. And not only that, there's probably only 24 to 96 wells per container. So you're not going to get a test that has more than that in it. We could make as many as we wanted to with a Vibrant chip because we have the ability to do it with the technology. We could add more and more and more and more and more tests. We don't have to worry about the number of wells, which is really important. And so I just wanted to show this because I love statistics. And when you look at this, these are some of the actual tests that we're going to be running, or that we're going to be talking about over the next several months. And by the way, I have no problem if anybody needs any help walking you through these tests and what it means. So that's not a problem, okay? So if people need help, I'm all for it. Now, when they did this, the coefficient of variation. So for those of you that are statistically literate, you get this. For those of you that are not, let me talk about this. This is how much standard deviation off of the mean, or the average, that we can have in order to have a valid test. And they set this at 20%. And that is based upon the effect size, or how many people are involved in their standardization process. If you'll look over here, very seldomly do you see anything over 5, 6, or 7%. And it's replicable between samples 1, 2, and 3. And they publish their white papers, which most people don't do. So having said that, there's a lot of people that say the technology is not reliable. It is. It's been published. That their coefficient of variation is not good. There is very little variance. It is considered acceptable by the scientific community. And every single one of these values has been looked at with more than one sample. So what I want to tell you is, we could go through a statistical sort of hoopla here, but it's really pointless, the bottom line is it appears that what we're looking at is accurate, and that's what you need to know. So when you look at these tests, you need to be able to say, is it accurate or not accurate? The other thing you need to be able to look at is this. Who came up with this stuff? Like, who's copying who? Nobody's copying anybody. What you have is a bunch of functional practitioners or neurologists or clinicians of different types saying, I would like to know, for instance, with pandas, kids that come in with behavioral disorders, do we have markers that can actually look at that? For people that have encephalitis, do we have markers that can look at that? Do we have demyelinating pathologies? Do we have markers that can look at that? So we're putting together a panel that can look at the entire nervous system, and I promise you this will grow. And here's the easy thing about making this grow. With a computerized mechanism version, it's easier to grow than it is ELISA, and standardization is easier. So if you have a value that you were just so hung up on, let the company know, let me know. We can do something about it. And I want to talk about this because there's people publishing papers, there's people making actually op-eds, and op-eds are worthless. They're just opinion pieces, and they're making opinions about what they think about a test that doesn't have anything to do with the scientific validity. And the scientific validity is what is important. And we're not going to get into a scientific jousting fight because we've already looked at our coefficient of variations. All right, so when we get to this, Vibrant said this, look, we're going to make a test. And we're going to make a test that basically nobody understands. And we know that this Neural Zoomer Plus is a test that is, it's not like a wheat test or even a mold test or a Lyme test where it's much more singular. It's much more secular. It's much more, put into a very short category. This test means a million different things. And there's a lot of different stuff that plugs into it. That's why it's so special. And that's why we're having webinars on it. And believe me, there's hundreds of practitioners that can talk about this stuff. One thing I want you to look at is that Vibrant America has a CLIA certified lab, and here's the number. I've actually heard that they don't. They do. And so when you look at the amount of knowledge that is put into the test, that has looked at the specificity, that has looked at the reliability, that has looked at the technology, then here's what we have to say. You can actually look at this stuff and say, I think it means something, it's reproducible, and it means something. So the very first thing I always do with a test is I run one on myself and then another one on myself from the same blood draw and see if it tells me the same data. This one passed muster. It gave me the same labs and the same values. And I can say a lot of labs do not do that, and that is scary. All right, so now we're going to kind of get into the meat of this. So I like to throw some papers in there and every now and then talk a little bit about what's going on here. So, okay, so we've got basically a test that looks at inflammation, and inflammation that's turned into immunity, and immunity that's turned into autoimmunity, and autoimmunity that has attacked brain tissue, the most precious tissue that you can have, the tissue that makes you be able to realize art, have relationship, have a job, have creativity, have all of these things that are so important. I thought, man, there's got to be some sort of publications out there that makes me think that this is actually related to what this has importance. In other words, does this test even matter? That's the question. When you order it, first of all, can you learn about it? And second of all, does it even matter? So we found right out of Elsevier, brain, behavior, and immunity. Now, the one thing I like to look at is 2015. So this is current. And this is looking at understanding inflammation, its regulation, its relevance for health, and looking at it as a public priority. So now you have due diligence. You need to take care of it. Your board demands due diligence. Relevance. Is this test even relevant? There's so many labs that are done that are irrelevant. This test is relevant. It is regulated. I just showed you the coefficient of variation. It is actually standardized. And then inflammation, if you go and you look at this next couple of slides, And what Hoyert and Zhu, these two guys in 2012, leading up to this 2015 paper said, they said this: all told, inflammation is involved in at least 8 of the top 10 leading causes of death in the United States. This is actually 6 years ago. So what we're looking at is an autoimmune test, and an autoimmune test is basically based in inflammation. And when you look at inflammation, you have to say to yourself, what are the inflammatory triggers? So here's the difference in what we're looking at versus traditional medicine, which I have no problem with. Eventually, you will look at the Neural Zoomer Plus as a piece of a string of possibilities in an equation. And I'll give you an example. You will do an inhalant test that looks at molds. This is creating inflammation. This is creating a Th2 response. This is creating antibodies. It's turning into a Th9 response. It is turning into antigen presentation, molecular mimicry. It's crossing the blood-brain barrier. It's now attacking various neurotransmitters or parts of the brain and causing clinical symptoms. It's not just you have dementia, or you have patchy white matter disease, or you have POTS. The world of medicine is evolving to the point to where you have to be an integrated practitioner and go all the way back to the beginning of the trigger and try to get rid of each part of the equation so that you can get rid of the summation of that equals the symptoms. And that is, to be quite honest with you, ladies and gentlemen, very difficult, but it's not unteachable. And it's the golden nugget that we're all looking for because we all know it's there. I see 104 participants on here right now, and I can tell you this: every single one of you is looking for that recipe. A plus B plus C plus D equals E. What order do I treat those in? What do I eliminate so that I can get rid of the symptoms instead of medicating away the symptoms, which does nothing to get rid of the equation that equals disease? And when you can do that, you can go home at night, you can sit back and you can say, I worked, I learned, and I changed. And when I do that, I don't need a billboard. I don't need a major advertisement. When I can explain it to my patients, they're going to eventually show up. That's the coolest thing. The Vibrant Labs are just a piece of me talking about that puzzle. I'm very happy that they have said, okay, look, we understand that story. Let us make the pieces of the puzzle that you need so that you can deal with that equation that you just talked about, Dr. Brock, and Dr. everybody else that knows the same thing. And by the way, everybody in integrated medicine, the reason why we're in integrated medicine is because we know that there is a beginning and an end to bad health. It's not just bad health, medicate and get rid of the symptoms and pretend like everything else doesn't exist. The brain is no different. The brain is just more detailed and more complex, but when you see it, it's really not. So let's take some of the fear out of it. Well, this is not a good slide to start to take the fear out of it, but let's break this down kind of slow. So one of the things I'm going to do is I'm going to talk about some labs. And by the way, I love what Vibrant has done, but I will talk to you about other labs that maybe Vibrant doesn't do. How about that? I've worked for companies before and done things where if you don't talk exclusively about their stuff, it is considered taboo. No. What's taboo is not telling the whole story. You cannot talk about antibody antigen responses if you can't talk about the nervous system. Because pretty soon, when we have a lack of function or health or, that T-reg cell dysfunction, or we get polarization of the immune system, we're either gobbling things up or we're making too many antibodies, but the bottom line is it's tissue destruction. And that's what makes, autoimmunity really, really, really problem. So as we're going through this, I just want to kind of show you the slide. Now, most of these slides are all from things like journals, and I like to, again, reference journals as much as I can. But as we look at this, let's just look at section 1. So these are your dendritic cells. Your phagocytic cells. These are the cells that eat things like pathogens and then just debris, PAMPs and DAMPs. So we've got macrophages, which show up as monocytes on your CBC. And then we've got B cells, and we've got dendritic cells. Dendritic cells are the major ones. They eat things. And then we've got neutrophils. And these are all antigen presenting cells. So they eat things and they say, hey, look, naive T cell right here. Naive T cell, this isn't a lymph node. I'm going to bring you this stuff and I'm going to say, hey, look, this is what we have sitting out here. You need to pay attention, and you need to either go one direction or you need to go another to either tag it or go eat it. I'll give you a good example of how this works. With a head injury, we don't always want to stop the inflammation right away because we're eating the debris. So if you put an anti-inflammatory in there too soon, unless you have intracranial pressure where you need like mannitol or you need some sort of prednisone, if we stop inflammation too soon, we leave necrotic neurons or dead neurons or neurons that don't make any ATP. So as the blood-brain barrier opens because of tumor necrosis factor, then the actual outside macrophages come in, snag all that stuff, go out, go to a lymph node, co-stimulate a naive T cell, and now we have brain autoimmunity. That's one of the reasons why our blood-brain barrier is so freaking important. Now, guys, it is very difficult to test some of these things because when you look at lymphocytes and they're not stimulated and you're just looking at stagnant cytokines, they mean nothing outside of a proliferative, ongoing environment. So it's very difficult to test some of these immunological properties. But let's just talk a little bit here. So we have Th1. So Th1 is a stimulatory pathway that uses various cytokines that further stimulates things like natural killer cells. I call those the Navy SEALs of the immune system. They kind of got their own sense of humor. They go out and do their own thing. They're very related to cerebellar function, and they're very much out on their own. They're very anti-cancer and antimicrobial. However, macrophages, whenever monocytes are in the bloodstream and they go into the tissue, they become macrophages and they eat things. And then they can go over to Th2 cells, which turn into plasma cells, and that makes an antibody. So an antibody is like this. It's like throwing a sticker on something and saying, come get me. And then the mast cells will depolarize and say, hey, everybody, come here, because there's a lot of antibody around and we need to kill something. So now we have things like Th2 responses, which are more of our antigen presenting, our Th1, which is more of our phagocytic. So we have cell mediated versus antibody mediated. And these Th2 can turn into Th9, which are things like asthma and mucosal mediated things and respiratory pathologies. We can run total immunoglobulins, we can look at mast cells, and we can look at eosinophils, and things like parasites will ramp this up. Various Th1 conditions will ramp this up. But the bottom line is they usually work together so that we can eat stuff and say, hey, look, make an antibody so that we now have immunity to it so that when it comes into the system, it is better eaten. All of that's cool until you start producing another cytokine that says nucleus. Don't respond the right way and become autoimmune to everything. And I'll show you that in a second. So this is really what we got. It's 7 o'clock. So now here's what we have. Inflammation develops for whatever reason. And the triggers are radiation, gut exposure, viral exposure, bacterial exposure, mold exposure, maybe SIBO, maybe trauma. There's so many things that can be a trigger. And I will share with you as we go on the triggers that we have. So we end up having these autoantigens. We have these antigen presenting cells, and they end up going to these lymphocytes that turn into Th1, Th2, or Th17. Now I want to show you something. I told you Th1 eats things. Th2 makes antibodies to things. Th3 is your regulatory cells. Vitamin D and a lot of your anti-inflammatories. And by the way, general health makes your Treg cells. Treg cells tell all of these things to cool it. Don't go eat things. and make it a component that's going to turn into an antigen presenting cells. Th2 cells don't make antibodies. Th17 goes over to a cell and makes a pro-inflammatory cytokine and makes microRNA that produces interleukin-6 that further damages the tissue, makes autoantigens, and promotes autoimmunity. So we may have a little inflammation and some antibodies. It's silent. We may be making some antibodies and have no clinical findings. It's silent. But when Th17 starts going crazy and Treg cells starts going down, we end up getting a situation where we end up getting autoantigens, autoantibody production, and we start killing our own tissue. And if you kill enough tissue and it doesn't do what it's supposed to, that's called autoimmune disease. So this is, again, right out of a paper. Anybody wants it, I can make it available. It's within the last 5 years, which makes it, and immunology is kind of weird. If it's between 2007, 2012 has changed, between 2012, 2015 has changed, between now and 2015 has changed. So I tried to give you something relevant. Okay, so now, let's say that we have a bad immune system, we have a trigger, and we have something that's making inflammation, and we have something that's making an antibody response. When it comes to brain, what are we looking at with a neural zoomer? And so with each follow-up seminar or webinar, I'm going to break each one of these categories down and tell you about the clinical findings, the nutritional treatment, and other labs that will be necessary. But right now, I just want to break down the general schematic of the Neural Zoomer Plus. And I think that this is super important because people don't even understand these categories, okay? So this is a look at somebody that has major problems with HSV1, which we know can live in the brain, create an inflammatory response, and cause just global inflammation within the brain. And it can lead to things like dementia down the road. And these are cold sores. So is there any relevance to HSV1, cytomegalovirus, Epstein-Barr virus, HHV6? If you look, we were all concerned, like, hey, look, we know there's triggers. We know there's infectious triggers in the central nervous system. So guess what they did for us? They put it, and I'll try to make a little pin mark here. They put it right down here in the infections. They said, we know there's cytomegalovirus. We know there's old roseola. We know there's streptococcus A for panda patients. We know Epstein-Barr virus has multiple stages. We know there's HSV2. By the way, HSV1 and 2 can go into both places, either or. And then we have HHV7. I will talk a whole webinar about just infectious disease and other labs you can run that will give you information about infection, how you treat it, how you deal with it. Some of it's drugs, some of it's nutrition, but it's no joke. If you have bad complement or bad immunoglobulins or a bad, basically a hobbled capacity to deal with infection, all of this can turn into a trigger for things like brain infection, which can turn into brain autoimmunity, or neuromuscular junction disorders, or a peripheral neuropathy, or it can go up to optical and autonomic like Pott's disease or neuromyelitis optica. And the blood-brain barrier can break down, and of course it can demyelinate, and demyelinating looks a whole lot like peripheral neuropathy. So when you look at this, I am going to build it in a sort of a pyramid where when I talk about one category and then talk about the next category will build on the first category, and then the third will build on the second and the first. And we'll make it to where you can run through these so quickly. And at the very end, I'm showing you the other tests that plug into this that can be triggers. And that's where a lot of people get confused. We realize that in one 1-hour webinar, there's no way I can talk about all of these antibodies and do justice. But I can talk about these antibodies, I can talk about autoimmunity, I can talk about inflammation, and I can start getting you on the process to where you feel a little bit more confident, even though you're not some sort of mega enriched neurologist. But you're a functional practitioner. And by the way, if you like the cardiac system, functional practitioners deal with it. The neuroendocrine system, same thing. Thyroid system, same thing. Brain is no different. And right now, brain is in big trouble because by the year 2040, we're looking at, 1 of 3 people having a neurodegenerative disorder. This is getting out of control. Some of the major drug companies are pulling out of some of the research for medications. And so what we're finding is one condition turns on multiple genes, turns on multiple antibodies, which attacks multiple areas, and people's lifestyle and lack of nutrition and stress and everything else is deteriorating their brain, and there is not one drug that will solve the solution. So for those of you that are nervous, you need to get through it, and you need to figure out how to learn more about the brain, and you don't necessarily have to be a neurodiplomat. So here's one of the things that I actually love about this test. And so I gave an example of anti-S100B, and these are blood-brain barrier disruptors. I only put these up here not to give you the details, but to show you that there is, when you're looking at the markers, there's a green, a yellow, and a red, and red is obviously a problem, okay? These glial fibrillary acidic proteins are so amazing. They should not be outside of the central nervous system. So when we find them outside of the central nervous system, it's even more sensitive than S100B, and S100B got all of the attention. We have multiple blood-brain barrier markers. And everybody wants to know about the blood-brain barrier, because here's what can happen after a head injury. Within 20 minutes after a significant head injury, your gut barrier can open up within 20 minutes. Your blood-brain barrier, because of tumor necrosis factor, can open up within 20 minutes. Your microglial cells can prime and make pro-inflammatory cytokines. We have to go through the nutrition. We have to go through the medications. We have to go through the lifestyle. That if you have these markers, you'll be able to make a difference in this person. So again, this is not just to show you these markers. I'm trying to show you the way that Vibrant has put this together. And we can see that right here, their IgG and IgA is very low. Their IgM is not that bad. And of course, the glial fibrillary acidic proteins are okay as well. So this looks pretty good. Can I rely on it? Yes. Is the coefficient of variation good? Yes. Is the technology proven? Yes. Is it CLIA certified? Yes. Is it actually more reliable than ELISA technology? The answer is yes. So as we go through this, it's pretty cool and it's reliable. So as we look at this, this is really kind of the meat and potatoes. And I'm going to jump through this fairly quickly and make as much material over the next 6 months so that all of these categories, every single one of you can be extremely happy, very confident, and be very clinical about this. And know when to hold them, know when to fold them. I don't want to put you in a situation where you feel like, you know, you're out of your lane. Okay. Some of the symptoms of the reason why we would even do this test, and by the way, these are extreme symptoms. Well, fever. Now, guys, remember, fever can mean a lot of things. If it's just encephalitic, or if it's infectious, or if it's infectious related encephalitic. Encephalitic meaning brain inflammation. Encephalo, brain, lytic, you know, we have those kinds of things. We can have encephalomyelitis, encephalitis. Headache is a very common thing. So in other words, there's headache for no reason. It's not suboccipital neuralgia. It's not cervicogenic. Maybe it's migrainous. Maybe it's not. A lot of times people have headache because they have inflammation, and the inflammation can create fever-like symptoms even though they don't have a fever. Head pain goes along with sensitization. Sensitization goes along with inflammatory cytokines, which can cause headache. Seizures. Guys, there's all kinds of markers that we can look at for excitotoxicity. So seizures are a part of this. Cognitive impairment is one of the biggest things. Mild cognitive impairment. You have that person that had a head injury, or they're starting to get early signs of dementia. One of the things I'll tell you is there's early confusion, there's mild memory loss. When you get things like acetylcholine antibodies, dopamine antibodies, NMDA receptor antibodies, and AMPA receptor antibodies, you will understand 100% why they are having findings of cognitive impairment. And then as we go back to the slides that I showed you, you'll be able to say things like, they've got this trigger, they've got this inflammatory response, they have a poor immune response, Treg cells are terrible, Th17 is up, these antibodies are attacking tissue, There's either a food response, a mold response, an infectious disease response, a gut response, or just a good old-fashioned neurological traumatic response that is creating inflammation and decimating their central nervous system. That is what we're trying to get you at. Yes, it is a little bit complicated, but I promise you, beyond a shadow of a doubt, it is 1,000,000% worth it to learn. Okay? The standard neurological environment is not running this. And when they say that this isn't valid, I would question what their information or knowledge is on statistical information on the actual standard deviation, the means, and coming off of the standard deviations and the means to actually look at norms. Speech, hearing, and language dysfunction. One of the things I'm going to build into this is left and right brain function and which neurotransmitters are more linked into which hemisphere. So if you have an antibody to that neurotransmitter, it can create hemisphericity. That should make all of you functional neurologists out there extremely happy, because the first question you have to ask if you're a functional neurologist is A, why did somebody get hemisphericity out of nowhere? B, why is it that my functional neurological treatment doesn't work all the time? And C, why do we always not get plasticity when we want to? Antibodies can be as a result of all of them. Antibodies can stop plasticity. Antibodies can create hemisphericity. And there's a million reasons why you might have inflammation that triggers an autoimmune response. So anyway, as we go through this muscle weakness with neuromuscular junction problems, now remember, I will give you the differences between neuromuscular junction and primary muscle weakness. You have to know the difference. One's genetic, one's autoimmune. And look at this. This next section right here, it's kind of personal. There's a lot of people that treat movement disorders, and the first question I always have is, why is there a movement disorder? And believe me, there's genetic reasons. I can name at least 15 to 20 different genetic components that are responsible for myoclonus, tremor, or even a dyskinesia. And I can even name the medications that are really responsible for dyskinesias, especially tardive dyskinesias. But why in the world are people not considering antibody responses? And I'll tell you why. It's called cognitive dissonance. Everything has to fit into a certain box or it doesn't exist. So if antibodies or antigen antibody responses are not on your radar, then myoclonus from autoimmunity must be from something else, and antibodies are not included. That's not the truth. It is not the truth. It's not the truth according to the literature. It's not the truth according to what we see clinically. And people have to realize, yes, you can have trauma. Yes, you can have genetic components, but yes, you can have autoimmune components. And guess what? We have the antibodies that look at some versions of myoclonus, a lot of versions of tremor, and a lot of versions of dyskinesia via the basal ganglia. Sydenham's disease. I got to tell you, this test right here can look at PANS, like your pediatric autoimmune neuropsychiatric syndromes. And I'm not even going to say related to strep, because we know we have more than one antibody, or sorry, more than one infectious agent now that creates these antibodies that attack the basal ganglia. This is the best test I've seen, because it not only does it look at the neurotransmitters, it looks at the D1, D2 pathways that relate to dopamine in the basal ganglia that can make you hyperexcitable or not excitable at all. And then it also looks at the tubulin that can destroy the structure. And then it looks at the other neurotransmitters. And then it looks at things that can make you slow down or speed up. So now we have other components of pandas that we haven't looked at traditionally before. We can get it way faster, way cheaper, and we can look at way more. So I'm very excited about that. Dysautonomias, our POTS patients. Why do people pass out when they stand up? Well, maybe they have acetylcholine receptors. Maybe there's 4 or 5 other autonomic receptors that we need to look at, or antibodies that we need to look at that can cause tachycardia, hypertension, even hyperthermias. And then, of course, finally, we have the optic neuropathies or retinopathies. And believe me, there's a lot of people out there that end up getting these, and now they have small blind spots or small scotomas, and you can't map a blind spot on them. You can't, the scotoma, you have to be able to do an Ansler's grid. Some of the saccades are not, they're not viable, or pursuits, they're not viable because they will scan through the area where there's a scotoma because they have a retinopathy, because they have an autoimmune response. So I'm spending a little bit of time on this only because I want people to know why you would do this stuff. This is all functional neurology. And by the way, what's the difference between functional neurology and functional medicine at some point? And then traditional medicine has to know this. Everybody has to kind of bind together and say, you know what? Enough of the territorial determination. We all need to come together to make the big picture for people who are sick that have no help. Nobody has an entire understanding of this puzzle. Notice there's a piece missing right here. This piece to me, and the reason why I love this picture so much, is because it's symbolic of the fact that we all, every single one of us, no matter what your background is, we need to still work together so that we can piece this together so the most important organ in the entire universe, which is your brain, can stay healthy. Okay, so demyelination, and this is where it starts. So we all know that myelin is the cover of the peripheral nervous system, and oligodendrocytes is the covering of the central nervous system. And if you look at a wire, any wire in front of you, it has a plastic coating, and we have to keep that plastic coating on there so the conduction is appropriate. So a lot of people think that this is a really replacement for multiple sclerosis. So if you have anti-myelin basic proteins, you have multiple sclerosis. And the answer is that's not true. You still need to do, if you think you have multiple sclerosis, you still probably, and this is where this is really cool. So if you get anti-myelin basic proteins and somebody has a scotoma, they have diplopia, they've lost the ability to see reds, you still probably need to do a spinal tap and look for oligoclonal bands. You probably still need to do a VEP and look at P100s to see if their conduction is slow through their optic nerve. You probably still need to do an MRI to make sure that there is no demyelination or major patchy white matter disease, in particular around the posterior genu of the corpus callosum. However, I will say this. If you have myelin antibodies, it could be bad for this. Conduction velocities. So what does that mean to a functional neurologist? Well, I got to do something to fix the immune system, or a functional medicine person. What does it mean to a functional neurologist? Maybe I can't use that pathway to activate the brain. If we look at tubulin, this is a classic structural antibody that cross-reacts from thyroid or an infectious agent that can go and destroy various tissues and also damage the neurons that deal with pandas, OCD, and so forth. These are ventral, brainstem, or mesencephalic neurons that go to the neostriatum to make your brain go through the D1 pathways or stop through D2. We also have the antibodies to not only dopamine, but D1 and D2. This is so cool down here, anti-neurofascin. It says some stuff down here about demyelination, but there's also something else, and I published this on my Facebook page. People with neurofascin antibodies have very difficult times promoting plasticity. So when I see this, I know as a functional neurologist, I'm going uphill unless I get rid of the inflammation first. And then when you look at things like anti-MAG, this is very related to peripheral neuropathy. I will put up some very good papers that deal with this, and it really disrupts myelin production in healthy nerves. So if you have things like myelin basic proteins and anti-MAG, then you're going to have a high probability of having some sort of neuropathy. The majority of neuropathies start out distal before proximal, lower before upper, and they don't and it's 2 or more cutaneous distributions in 2 or more nerves. If you have that, rule out diabetes. If diabetes isn't there, okay. Rule out thyroid. If thyroid isn't there, okay. If you have a polyneuropathy for an unexplained reason, this is your test. And I can tell you the other labs that run these, peripheral motor sensory neuropathies, they're upwards of $15,000 to $20,000 on some of these. It's just unrealistic. And to get an insurance to pay for it is very, very difficult. So I would just say that this is one of the best bangs for the buck that's ever happened. the majority of us that are doing this stuff, when we look at it, we're like, thank you, thank you, thank you. So I put in an abstract for here, and a lot of people are like, you know what, this stuff it has nothing to do with polyneuropathy. Well, how useful are antineuronal IgM antibodies in the diagnosis of chronic immune-mediated neuropathies? And we went through here and we looked at this, and we showed that indeed, people with polyneuropathies, even people with diabetes, which by the way have bad immune systems, even people with thyroid that have bad immune systems, a lot of them had the antibodies that we're looking at: MAG, GM1, Humulin, all these different things that I'll be talking about later on. These antibodies are highly involved in peripheral neuropathies, and until you fix the immune system, there's really not much you can do about it. So blood-brain barrier, I'm very proud of this, because a lot of people are just, hey, it's anti-S100B. It made national news. I did stuff as a Fox News contributor, and I can tell you that anti-S100B, when it came out, it was everywhere. But anti-glial fibrillary acidic proteins are really more sensitive. And then look at the microglial cells. So for all you that like football and you look at traumatic brain injury and you look at chronic traumatic encephalopathy, here's what happens. The blood-brain barrier breaks, microglial cells get primed, they turn on, you end up getting destruction related to these glucose-related protein 78s. I'll show you what those mean in a little bit and more later. But S100B promotes inflammation. These guys seep out. Microglial cells make inflammation. These guys promote it. It stays on. The microglial cells don't turn off. They get primed, and it starts destroying your brain. And now you have things like Alzheimer's disease. Or I could scratch this out and say possibly even CTE, chronic traumatic encephalopathy. There's so many neat things that we can add just to these inflammation, these little, sort of summaries that are on the test, and we will. And I threw this on there. This is actually a paper that shows these Tolllike receptors. This is S100B. S100B promotes an inflammatory response. We look at these anti-aquaform P4 antibodies. This is almost the exact same thing as this anti-glucose regulated protein. But when you look at these guys, they all work together to either promote inflammation, damage the blood-brain barrier, activate plasma cells, make antibodies, and now we do things like turn on these phagocytic cells to go eat things. We don't want the blood-brain barrier to be leaky, and then when it becomes leaky, we don't want to turn on the immune system inside to start eating the tissue that we need to keep. And you look at these MOG antibodies and all these things. The Vibrant test looks at pretty much all of this stuff, and pretty soon you'll be able to put it together in a story and say, the blood-brain barrier is broken, we have an inflammatory response, microglial cells are activated, there's sustained cytokines, and this whole thing, all hell is breaking loose, neutrophils are going crazy, and it's eating various tissues, typically the hippocampus and the frontal part of the brain. So now we're photophobic, we have behavioral changes, we have short-term memory loss, we have balance problems because of central mediated changes. Now you know what a head injury patient looks like. And of course their pursuits look bad. Their neural integrator's off. Of course they have bad targeting because they have Purkinje or cerebellar antibodies. All of this stuff can be explained because of inflammation, and a lot of it with antibodies. Not all of it, but some of it. So we look at this, and now we have autonomic nervous system disorders. And of course, there's this big, long-standing myth that if your brain changes, your pontomedullary reticular function changes, and that makes your autonomic nervous system go crazy. Well, there's static and dynamic components related to autonomics, and they are really related to the dorsolateral prefrontal or the prefrontal cortex, right being one part, left being the other part, in regards to dynamic and static components. Our pontomedullary reticular formation got put into this gigantic story a little bit on urban legend. But we have some antibodies now that look at things like recoverin, which is very important in regards to vision impairment, photosensitivity. I can't tell you how many head injury patients have recoverin antibodies. We've actually got some antibodies that are actually a little bit scary. And they're paraneoplastic, meaning they could be signs of cancerous types of processes. And I'll show you what that means here in a second. But then we look at things like anti-neuronal specific enolase, which are antibodies really found in patients with optical neuropathies. Now, there's one on here that is not on here. It's just NMO antibodies. Neuromyelitis optica is not up here, but that's basically MS that is just basically specified to the actual optic nerve. Now, we did an anti-aquaporin 4 that looks like neuromyelitis optica. Gives you the same symptoms. The eyeball hurts, the optic nerve hurts, it hurts to move your eye, but at the end of the day, it's not complete MS, it's just really peripheral demyelination of the optic system. How in the world can you have saccades? How in the world can you have pursuits? How can you pursue into a field that you can't visually see because you have retinal pathology, because you have an antibody to it? It doesn't mean that's the absolute cause, but it means you need to rule it out. Why wouldn't you do it for a test that has high specificity, good sensitivity, is at a realistic price, and you get it back relatively quickly? Why would you not do it if you're a functional practitioner? That's my question. Now, one of the big things is this: the brain's inflamed. The brain is inflamed. It happens if you have a head injury, it happens if you have an infectious disease. And if you look at this, we have onconeuronal and autoimmune synaptic differences. It took me about 4 hours to find this paper. But we have these antibodies here and we have these antibodies here. We have NMDA receptors, we have AMPA receptors, we have GABA receptors, we have different types of receptors over here, especially MA. And we can say, man, this looks onconeuronal or this looks autoimmune synaptic. Think about trying to create functional neurological synaptic plasticity through the Hebbian process when you have antibodies that are actually stopping the synaptic process. Same thing if you have an onconeuronal process. Wouldn't you want to know about this? All of these things, FDA-approved drugs, are made based upon the stability of these markers that we're using that are highly sensitive and highly specific. So when we look at this, I love peripheral neuropathies. It was one of the first things that I ever loved about neurology because I did so many electrodiagnostic studies. And the GM1s are so related to those motor neuropathies where you get motor more than sensory. So I told you a second ago that polyneuropathies are typically sensory, typically distal, lower before upper. But if you get motor neuropathy before sensory neuropathy, you've got to look at Charcot-Marie tooth, which causes atrophy. If it doesn't cause that atrophy and you get rapid onset of multifocal motor pathology, it's GM1, which has a lot to do with Guillain-Barré. That has a lot to do with Campylobacter infections, and there is a molecular mimicry or cross-reactivity in the two. You look at the Antirime, and this goes back to right here where I showed you this, classic onconeuronal. You come over here, if you have this, can be detected in patients with paraneoplastic. Look at this, real quick, just please pay attention. For all of you functional neurologists out there that are not testing this, that have opsoclonus, myoclonus, if you read the papers on this and you have this, and you are finding opsoclonus, myoclonus, are brainstem variabilities of motor disorders where people are dropping to the floor and you're not looking at this, you're in the wrong. It's easy to do with one test. You have to ask yourself, why did it start in the first place? I can guarantee you I've seen patients in my own office where patients have come from very prestigious offices. They had this and they had other processes going on that were making opsoclonus with their eyes and causing myoclonic jerks and drops. And it was all neoplastic. Okay. You looked at the amphiphysin, and that is right here as well. Once again, these are onconal things, and these are people with stiff person syndrome. You see it in their spine. They get very stiff. The last seminar I was at, somebody said, I think I have somebody with stiff person syndrome or stiff man syndrome. And we actually have an antibody for that. There's more than one. So the thing I wanted to throw up that I think is really important is these are the antibodies and these are the common cancer associations. I thought I would at least throw this up. Now, I guess I can throw this up. I don't know what I can and can't promote, but functional medicine meetings, we are doing a lab certification series. And we will be talking about things like ominous markers for cancer, acute phase reactants, the things that you would look at and then you would not look at in regards to cancer. But when we have things like humulin, yo, rye, ma, recoverin, these are all possible cancer associations. So even if you're not an oncologist, it doesn't matter. If you find these antibodies, you got to say this. There is a possible, look down here, paraneoplastic cerebellar degeneration. 3 patients last year came into my office from other facilities, and they had cerebellar conditions, and they ended up with paraneoplastic issues, and they were as a result of cancer from other places. It doesn't matter if you're an oncologist or if you can do chemotherapy. What matters is that you can actually find the condition. And I'm very, very thankful for being able to find some of these. There's other labs that have run some of these antibodies. I'm glad that we have a lab now that can put them all together where you don't have to sacrifice an arm or a leg to do it. This goes back to just normal reactivity, GM1, GM2. This shows Campylobacter, very, very common for causing things like a GM1 attack at the node of Ranvier causing Guillain-Barré. And now the person can't breathe on their own. They can't even blink. They're just sitting there laying in desolation. Neuromuscular junction disorder. So here's the difference between a neuromuscular junction disorder and a primary muscle disease. With a primary muscle disease, we have things like proximal weakness and muscle wasting. With a neuromuscular junction disease, you have weakness with overactivation. So if you contract your hands or contract your face, you end up with weakness, but there's no atrophy. And we see that in things like myasthenia gravis. We see it in Lambert-Eaton, which is the myasthenia gravis of the periphery. I can't believe how many Lambert-Eaton patients I've seen that are very, very silent. It's been very, very surprising to me. And I'm not going to spend a lot of time on this because people aren't going to see a lot of neuromuscular junction disorders, but you need to be aware of it because people that are weak or they get weak when there's activity, you want to think neuromuscular junction. When they get weak when there's heat, you want to think POTS. When they get weak when they go from laying to standing, you want to think POTS. When we do POTS, blood pressure is not the standard anymore. Heart rate variability and changes in pulse is now in the literature as the standardized way of actually diagnosing these things. But antibodies can actually cause some of these problems. So this says brain autoimmunity, and these are just various areas that can get autoimmunity. Purkinje cells are cerebellar cells that are GABAergic, and they inhibit the output of deep cerebellar nuclei that cause activation to the brainstem. So when we have Purkinje cell antibodies, one thing that's not up here is cerebellar antibodies, and the cerebellar antibodies are more in the cortex. We have cerebellar findings, and what are those findings? Hypotonia. See, this is what I'm going to do on the follow-up webinars. One section on brain autoimmunity. What does a cerebellar or Purkinje cell antibody look like? It's hypotonia. It's ingaze nystagmus. It's actually pursuits in both directions that are non-smooth. It's actually fine motor skills that break down with movement, not at rest. So I can give you the clinical findings that will tell you if the antibody is really clinically active, and then you can say, they've got this antibody, they got the clinical findings, we can do some imaging, they've got atrophy of the cerebellum, they have autoimmunity, they're an alcoholic, their thiamine levels are down. I mean, we can go in all kinds of directions, and I can give you the nutrients that can actually correct those things and help those things. And thank God the cerebellum is the most plastic area because you can do something about it. There's not much medication that can. Now, the other thing I will say is this. There's a lot of genetic cerebellar disorders, so you need to know the difference, and I'll go through those. It's no fair to just talk about one test and not the other things. So many things like RAGE peptides that deal with blood sugar, insulin, and Alzheimer's disease. Tau, again, Alzheimer's disease. Glutamate, encephalitic, excitotoxicity, all kinds of different conditions. I can show you the genetic combinations between schizophrenia, the antibodies, the genetic combinations, and the clinical findings, and show you what it all looks like together. With dopamine, you guys know this is Parkinsonian. If you get it bad enough, it's supranuclear palsy. Like if you get alpha-synuclein and dopamine, you're going to get dementia and Parkinson disease. Okay, so all of these things, really look at this. So cool here. Your B2 adrenergic and anti-A1 adrenergic receptors, you see this in unclassified Lewy body and vascular dementia. These are people with like multiple systems atrophy, or they get small patchy white matter disease on their MRIs. And you may say, man, this is freaking, you know, wheat, which it could be, or this is just small vessel disease, which it could be. And then we have, to top it off, an endothelial A receptor, which is also found in vascular receptors. So if I have this and this, I'm going to do an MRI. If I have this and this, it's probably Parkinson's. If I have this, this, and this, it's probably Alzheimer's disease. If I have this, it's probably a cerebellar-based tremor. So when I look at this, I can look at all of my tremors. It's so cool. There's a picture I'm not going to go through right now. If you have antibodies to NMDA receptors, good luck getting plasticity with functional neurology. And AMPA receptors carry the action potentials to NMDA receptors. And GABA receptors are screwed up. Look at this. We have dopamine receptors. They can cause Parkinson's and pandas because we broke it down. And we have all of the encephalitic glycine receptors is very, very interesting to me because we have things that can create things that look like pandas or excitation. It's not just D1 and D2 antibodies and tubulin and calcium calmodulin anymore. Now we have glycine receptors. Now we have, if we go back, now we have things that are related like A1 and B2 adrenergic receptors that can also cause some very similar symptoms. So we're starting to get PANS or pediatric autoimmune neuropsychiatric symptoms that are not just related to strep anymore. And by the way, we have all the encephalitis or brain inflammation markers. We have an anti-dipeptidyl aminopeptidase like protein 6, and we have a MAW, and these are all just meaning this, the brain's inflamed. And now we have the infections, the cytomegalovirus, the HHV6, just common encephalitis and epilepsy in temporal lobes. HHV7, very, very, very common, again, with not just encephalitis, but meningitis. Now, guys, we're talking like roseola infections. We're talking about mono infections. We're talking about cold sores. We're talking about genital ulcers. And look at this. We finally have an anti-streptococcal A, which you can correlate with your ASO and your DNase and your dopamine and everything else that's on the test. This is just looking at sort of some things like what HSV will do. The thing I kind of want to finish up here with, and I know I'm running a little bit long, and I appreciate for you guys just hanging out because this is so much fun. Look, we have LPSs from gram negatives. We have infections from anywhere. We have stress. Cortisol will destroy your hippocampus. Insulin resistance and leptin resistance will make you eat more, gain more weight, fire off platelet coagulation, change aldosterone, change sodium. If you guys are getting fat cells and get leptins that are going out into the periphery to slow down your hunger, you may get resistance, and then you make more leptins and it goes right into your joints and eats chondrocytes. So you can actually look, and this test doesn't do it, but there's other tests that look at leptin and adiponectin ratios, and you can say you're obese and it's causing inflammation and it's making your joints be destroyed despite your weight on the joint. So look at this, guys. Any of these triggers, NF-kappa B, that just means this: inflammation, activation of immune cells, reactive oxygen species like peroxynitration, chronic inflammation. Chronic inflammation equals your Treg cells going down, your Th17 going up. And now we have all these inflammatory mediators. And look at this: neuropathy. Brain fog is inflammation of the brain. Dizziness is all that encephalitis in the brainstem. Migraine, serotonin receptors and trigeminal system shutting down. If your brain is inflamed, your heart's inflamed. And then finally, we have autoimmunity. They all go together. So when you do this, you have to say, okay, look, I've got a Neural Zoomer Plus test. I'm talking about it. I'm going to be talking about it probably for the next half a year. But I need to know the physical exam. And I'm going to talk about that. What are the physical exam findings of each single marker? Is it there or not? Is it clinical or not? Is it turned into a true autoimmune disease or not? Food sensitivities. Are you eating a food that is cross-reacting and causing inflammation and crossing the blood-brain barrier and now attacking the brain? So I'll talk about food sensitivities. Is your thyroid creating immune dysfunction, where now your immune cells and the differentiation and turning into cytotoxic T cells or T regulatory cells or CD4, CD8 cells are all tied into your thyroid? And then do you have thyroid autoimmunity that cross-reacts with your cerebellum or your gut? I'll talk about that. I'll talk about the gut zoomer. Do you have a leaky gut? It can screw up your brain. Guys, the literature is so clear now that there is a link between your brain and your gut and your gut and your brain. If you run these two tests together, you can put it together. The genetic tests, I love them. When there's antibody tests, cool. When there's genetic tests, cool. If the one's there and the other's not, you can explain it. If they're both there together, we're starting to see trends in various conditions. MTHFR, MTTR, catechol-methyltransferase, glutamate receptors, serotonin receptors. These are not urinary neurotransmitter tests. These are genetic tests, plus the antibody tests, plus the physical exam findings, and now you start getting various conditions. If you really want to get fancy, you can image the brain and do diffuse tensor imaging or actual functional MRI. We can look for SIBO. The most common things I see with SIBO outside of gut problems is the following. Anxiety is a big one, and depression. These are big ones that I see because the lithocolates and different things that are produced that are inflammatory byproducts create damage to the gut. Now, there is hydrogen producers, there's methane producers, and now there's hydrogen sulfide producers, which make up the percentage really of the test that is considered negative on gas testing. So they say that these, breath tests are only about 60 to 70% positive or have a, sensitivity rate, but there's one gas they're not testing for, even though they have all the symptoms. And hopefully we'll be working on a test that will look at all three gases, not just two. Of course, you can have detoxification error. So many kids come in and see me. They're taking various medications for whatever the condition may be. They're not biotransforming it the right way. It's turning into inflammation. It's crossing the blood-brain barrier. It's causing damage, or it either metabolizes too quickly so they get a giant dose of it, or it metabolizes too slowly and they get none of it. So this year alone, I've had 4 kids that have come in with so-called pandas, and what we found out is they were just on the wrong drug. So very cool stuff. Heavy metals, we now have a great heavy metal test. And by the way, I'll talk about things we can do with heavy metals. It's not always the best idea to chelate these things out, especially when you have a bad immune system. The neuroendocrine system, it can screw up everything. Mycotoxins, I think we have one of the best mycotoxin tests in the world. Brain imaging, I will talk about this. The place where I work, we have a DTI imager. I can show lots of axonal tracts, tractography, and we can show digital specs, or we can look at spec scans, or we can look at where it looks at pixelated findings, areas that are functional or not. It ties in with your antibodies beautifully. We have a great, not just Lyme test, but tick-borne diseases. So look at this. People call me up, they're like, I got a neural zoomer that's positive. What's the trigger? Do they have thyroid symptoms? Do they have gut symptoms? When they eat, do they bloat like with SIBO? Do they have skin problems and all kinds of detoxification problems? Does it look like heavy metal? Is it a mycotoxin problem? Is it tick-borne? Do you know the physical exam stuff? And then finally, in the end, do you understand treatment protocols? That's where we're going with this Neural Zoomer Plus. It's not explaining it in one thing. It's saying this is what this test looks like. This is one of the most complicated tests that we've ever seen. We can add more to it. We can do more with it, but we have to be able to explain what we have and understand everything that encompasses around it so that we can say, I've got a bad brain because I had a mycotoxin exposure, and that mycotoxin exposure, how do I treat it? What can I do to seep it up in the gut? What can I do to change it in the body? What can I do to change the immune system? And are you genetically susceptible to it? All of these things are going to have to come together for you to be a Neural Zoomer expert. It's not like we're just going to say, hey, just memorize the antibodies and you got the whole story. The whole story is you becoming a well-rounded practitioner, and I gave you this as examples. So this is just a real quick test. I look at my total immunoglobulins to make sure that the things that stick on cells are there. Are my natural killer cells good? Is my complement good? That's what's connecting the cell that's going to kill things to the cell that needs to die in the immunoglobulin. Does it connect together? Do we have complement? Are mast cells out of control? Do we have bad histamine responses? And what are our diamine oxidase levels look like? Oh, sorry. We'll go through all of these things and talk about what they mean and talk about what you can get through Vibrant, what you can't get through Vibrant, and we'll put together an entire picture to where you understand it from A to Z. But here's the thing. You don't even know what A and Z is unless somebody sits down and kind of starts to work through it with you. We need to know the triggers. We need to know the end stage antibodies. And then we need to know how the immune system works between the trigger and the end stage. And then can you do a physical exam and determine if this is really autoimmune disease or not? And if you can do that, the neural zoomer will be a very easy thing. And we will talk about some MRIs. You may need to do some EEGs. Maybe you need to do a PET scan if some of these are oncological. Maybe some CSF studies if you think there's MS. Maybe serum. This is all serum. But bottom line is this. You're either going to find these cases and say, I'm going to treat it, or you're going to find these cases and say, I'm going to refer it. But either way, you're a hero. So listen, come back to these. Come back to each of these, little get-togethers that we're doing. There's so many different things. If you look at the very front page, that's all the stuff that I'm involved in, where we've tried to actually talk about functional neurology. We've tried to talk about immunology. We've tried to talk about nutrition and even medication. And this is one of the platforms that I have where I can start to pull it all together because it's one test that looks at so many different things. If you can master this test and everything that's around it, you will truly be amazing. And you will be able to say that HSV is a trigger that caused alpha-synuclein, which is a dopamine breaker, and the ventral tegmentum starts to die and the compacta dies. And now they're prone for Parkinson's disease. And the cerebellum combined with this makes an essential tremor. And we know that mom makes encephalitis. If you start to do that, you can run the other tests around it, like a thyroid test is imperative. A physical exam test is imperative. You've got to talk about different scrapes or different types of presentations where the HSV turned on. You need to see if they actually have a tremor, if they're rigid, bradykinetic. And then you have to see if they have an intention tremor or a resting tremor. And then, of course, with encephalitis, they may have findings where it waxes and wanes in the brainstem. That's a real quick presentation of what we're going to be looking at, where we're going. I promise you, if you come back, this is going to be the coolest trip that you take. I'm excited about it. I'm very thankful for Vibrant for letting me do it. When you guys have questions, I don't really know how to field them because I'm actually running the screen.
Dr. Bach, I can read them to you, or if you see in your that little control panel, there's a Q&A and there's also a chat. So people can type questions into either one of those. And if you don't see it, let me know. I can read them to you.
Okay. So I look here at Kathy Swift. She asked me which antigens are elevated in transverse myelitis. Well, let me tell you this about transverse myelitis. First of all, do an MRI. It shows up very clearly. The other thing is, please look for long track pathology. That's upper motor pathology, that's hyperreflexia and stuff like that. So you would really look at some of your clinical presentation and your some of your imaging before you would actually look at some of these antibodies. I don't know which ones would be. It could be myelin basic protein. It could be the other ones. The patient later develops ALS. Well, here's the thing about ALS, and here's the thing about this. The patient didn't really get demyelination. With ALS, that's ventral horn cell disease, and that's where you get, here's what happens with ALS. With primary muscle disease, your proximal muscles die off before your distal. With ALS, like with Lou Gehrig's, your distal muscles, like your hands, die off before your shoulders. But here's the very, 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 very interesting thing. With ALS, we get corticospinal pathway atrophy. So you look like you have upper motor pathway disease, and the long track disease looks like demyelination. So here's the one rule for ALS. You get upper motor findings in the lower extremities and lower motor findings in the upper extremities. So I would probably say that either transverse myelitis or demyelination might have been confused with the ALS. And look, if they have ALS, they're dead within a few years. That's one of the ways you know. So I hope that answers some of it. If you have any other questions, I would say email and we'll go through it. Okay, Kat, what's going on? A patient with very high Epstein-Barr antibodies and serum too high to measure had negative Epstein-Barr on Vibrant. How do I reconcile this? Well, there's a couple of things. The first thing is I would do a heterophile antibody test, end of story. IgM is, you guys got to understand, an IgM antibody is acute. An IgG could be a marker. If IgG is 4 to 5 times higher than the upper limit, it might be a chronic infection. But in order to understand if it's convalescent or not, sometimes you have to go to your standard labs and you have to run a heterophile antibody where you look at the viral capsid antigen and a couple of other things, and it'll put it together on a chart for you. So sometimes I combine those two together. Okay. If you have antibodies that are in the highest range of normal, can you safely ignore them? Okay, Sarah, I'm not sure I understand. But I would say this, with certain antibodies like IgG, for instance, yeah, you can ignore some of these. They're just signs of that you've had past infection and you have a blueprint.
Yeah, what I think she's asking, Dr. Brock, is so we have those cutoffs of 10 and below is considered, optimal or non-reactive or negative. And then you have moderate, which is between 10 and 20. So like anything up to 10. So she gave the example of 9.9. So and this is a common question asked of all of our testing, if an antibody is not above that cutoff. So Alin, I can actually tell you that the way that these are built is this is a standard 95% confidence interval, or in the case of this test, we're not measuring the bottom end of the tail. We're actually just taking the top. So anything 2.5% or the top 2.5% of the most reactive values is considered positive or high risk. And then between 95 and 97.5% is your moderate. So if you fall, if 9.9 is where the actual value is, that is below, that is where 95% of individuals in the validation or to establish the reference ranges fell. So that means that's the significance of that number.
Yeah, and I will say this, that 95% confidence interval is the absolute standard of statistical calculation. So let me explain something real quick. I'll give you a quick explanation. Maybe this will help. IgM antibodies, the tiger's out of the cage running loose in your blood. IgG, it's in a cage. You got guards around it. If it's too high, the tiger's jumping around. It takes more guards. PCR is DNA. It may not be in there if it's hiding in the tissue. If you want it to show up, go get a nice hard massage. And if you do that, it'll actually push it into the bloodstream, and sometimes it shows up positive. PCR does not always equal IgM, does not always equal IgG. So I really think that at some point in time, we need to talk about antibodies, complement, and the way antigens and antibody talk to each other. Would that be fair enough? So I hope so. Okay, so looking at and Dr. Rosenthal, thanks for your questions. They're great. Anti-glucose regulation, protein 78 is often associated with either gastric or hepatic cancer. Yes, possibly. And remember, like if you're coughing up blood and stuff like that, number one cause of gastric cancer, smoking. I've seen one with a very high IgG and IgM titers. Always get those things checked out. If any of these are common neoplastic antibodies, and we might need to do another test that says, hey, look, when these are positive, think neoplastic process. That way you don't end up doing something ridiculous that can end up hurting the patient, because some of these antibodies are signs that there is a neoplastic process. So maybe we need to go through that. But if you're catching gastric cancer, you're saving lives. So I don't know if I answered your question, but good job. We got Roger here. Roger, what's up? Good to see you, my man. Are you including this info in lab series you're teaching starting in March? Roger, here's the deal. Let me tell you about our lab series that we're doing in March. The answer is yes and no. There's only so much we can include in a lab series. I've been in situations where I had 3 days to teach everything, and we're doing 4 different classes to do the whole class. Yeah, some of it will be included, some of it won't, but I will also be making a lot of separate videos on my own that will explain different types of labs. And I will break one marker down, like this is what a globulin means. This is what albumin means. This is what a total protein means. And this is when you look at total proteins and albumins and globulins, this is what it means to swelling in your legs. This is what it means to antibodies. And this is what it means to cancer. And this is what it means to starvation. So it takes a long time to get through every single lab. And you can't just take a 1 weekend course. You got to go through it. You got to watch some videos. You got to practice it. Somebody has to quiz you. A neural zoomer is one part of this. Listen, it doesn't matter what Vibrant thinks. Here's my opinion. A neural zoomer is an amazing part of one gigantic, beautiful story called labs. Learning labs is like reading Braille. And I mean no disrespect towards people with vision impairment, but what I'm saying is when you learn to look at a lab and the answer immediately comes to your mind, you know you've done your homework. A neural zoomer is part of that. Just like a mold test is part of that. Just like an IBS test is part of that. Just like a a wheat zoomer is part of that. Just like a CBC is part of that. We got about a year to try to link a lot of this stuff together. Vibrant has decided to be a part of that. They want to include their stuff. There is nobody that has an answer to everything, but we're going to try to hook it all together so that you, the practitioner, can do things that make sense. You can use nutrition when it needs to be used. You can send them up for medication when it's necessary, and you can be a good clinician.
Okay. So one thing I wanted to add before we run out of too much time, what will be upcoming will be in our new education portal. There will be training modules for each of the wellness tests that we have. So, wheat zoomer, the food zoomers, the gut zoomer. There will be video modules, including tests, and you can download the slides. Dr. Brock will be making a series of modules that will be for the Neural Zoomer Plus. So those will be, as he makes them, we will, let you know, hey, these are available in the portal now. So over the course of the next, I don't know, what did we say? Something like 6 to 8 months, probably. Those will be something that you will see come out. And I think his plan was to do a module on each section of the test. So each one of those will go into, significantly greater detail than tonight, explaining what the panel is about, what the markers mean, and just like he said, what you would be looking for in terms of symptoms, what types of treatments might be relevant, when to refer, things like that. So for those of you who are really hungry for more information, just know that those are things that are coming up, as well as some, written guides to help with interventions and things like that too.
Yeah. And remember, guys, there's one thing I will say, and I don't have to say this, but the staff that's helping out with Vibrant is amazing. And you got to realize that there's very few people that understand everything about neuroscience. And I'm not one of them that understands everything about it, but I know quite a bit. Everybody is on a path to learning, and they have done so much amazing stuff. And the amount of information that we're putting together that's written and that's growing is going to be for you. We don't want to just charge you $1,500, wait 3 weeks, not give you any support.
It's 8 o'clock.
Not give any support, and then just say, hey, you're on your own. We've got to educate people. And then real quick, I'll answer these last 2 questions. So what do you do in an asymptomatic patient with lots of positive antibodies and a neural zoomer in most categories such as CMV and HSV 1 and 2? Well, join the club. Most people have cold sores, and a lot of people have genital herpes, and a lot of people have never had outbreaks. And CMV, almost everybody had roseola. It doesn't always equal pathology. And I want to say something. Don't always look at a neural zoomer and be jaded or taken to a position where you think that test has to answer your question. You may have symptoms of mania and it's hyperthyroidism. So that's one of the things about what we talk about and what we learn about, and the reason why you learn multiple labs. And you say this, a Neural Zoomer Plus or any of the tests that Vibrant do give you answers, or they're just distractors to something else, and you need to learn the other things. Listen, I'm very much altruistic to education about labs, regardless of who it is. I like Vibrant because of the reasons that I have said. It is sensitive, it is specific, it is cheaper, I have good turnaround, everybody there has good intentions, and the technology is way ahead of what the people can even tolerate. So having said that, I feel like this is a worthy cause, but don't be distracted always by a Neural Zoomer. And then the last thing is diagnosed with SIBO. If anybody wants my SIBO protocol, I've got one for hydrogen, I got one for methane, and within 30 days, it works about 85 to 90% of the time. If you want it, you can, I'm going to just take the heat off Vibrant right now. You can just send it to Dr. Brock, my Facebook, Dr. Brandon Brock, or you can send it to Dr. Brock, TWU@gmail.com. My wife, who's a health coach, will be more than happy to give you that information. And
Dr. Brock, we could email that to everybody if you would like. I can send an email to the attendees and registrants if that would be easier than you answering emails.
Oh, that's fine. But I will tell you. I'll tell you. So here's the deal, and I'll kind of end with this. I love treating SIBO. Like I think it is probably one of the most underestimated, devastating conditions that there is. Like, for instance, 90% of alcoholics have it. 75% of adults, like elderly, have it. Listen, in my family, I've treated 5 people this year with SIBO. They all are like crying and saying, thank you for changing my life. That is the reason why we get up and do this stuff, guys. Look, you know you have a rush when you do this. And the rush is somebody got better. And you know you strike out. I strike out. We all do. But there's always those people that it's like, I nailed it. And what did I learn? We spent 4 years putting the SIBO protocol together. Now, I will give you the disclaimers. I have no problem. My stuff is done with Zymogen products. I use a couple of other companies. It's okay with me. It's what works. But I use a lot of Vibrant tests, and their outcomes are very important to me by doing outcome assessments with labs. And when you change SIBO, you have changed somebody's life when they had diarrhea every day for 10 years and they're a 55-year-old female. So having said that, I guess it's a good way to stop is on diarrhea, right? I did that for Dr. Barry.
Dr. Barry, we'll put him on the spot one day. Dr. Brock, on behalf of everyone, I mean, obviously, you know, the chat is blowing up with just thanks, and this was so helpful, and we really appreciate the information. And this is, obviously this is scratching the surface, everyone. There's no way to distill, functional neurology into a 1-hour webinar. So we definitely will be following up with some modules. There will be additional information to come. Don't worry, we've got your back. Dr. Brock has your back too. And, there's a series of speaking events that he does. I know that there's one of his colleagues, Dr. Barry in Arizona, also does some speaking engagements. He talks a lot about the same things. So those will also be things that you'll see some advertisements for, where you can actually go and learn live, listen to them talk, listen to some of the therapies that they talk about, and some of the testing and the interventions. So we'll definitely send that information your way. And Dr. Brock, anything that you want sent out to the attendees or registrants, if you would send to me, I don't mind emailing it to everybody. That way you don't have to individually reply to everybody that requests it. We can just send it to everybody at once, if that's easier.
Yeah, and what I'll say is this. Number one is I am very thankful. I will say Dr. Barry has been, if you guys haven't had a chance to do one of his seminars, he's great with lasers. Dr. Teams is amazing. I can't say enough about the people I've learned from. I've learned from Stephen Stahl, who's medical psychiatric. I've learned from Dr. Karazian, who has been fantastic at immunology. I've learned from Dr. Carrick, who's been great at functional neurology. These are people I'm not ashamed of saying who have been fantastic in my life. I am a day walker, so to speak, meaning I do chiropractic and medicine together. But that's okay because we have to bring this stuff together. I am going to be doing this, and I'm going to pledge something to, this is the Vibrant, really. I'm going to take a marker a week, and I'm going to talk about what it means, and I'm going to put resources or references around it. And I've already done this once. This is going to be on my Facebook page. And by the way, I don't get any money for a Facebook page. All I get is people that can just come together, and I share everything on Vibrant's Facebook page. So it's just Dr. Brandon Brock. Just come like it, come on it, check it out. I'll be posting stuff on it. It's all about education. I've got plenty of patients, lots of stuff to do. It's about people learning. At the end of the day, when you're about to die, you just got to be able to say, did you do anything to help people? My best friends, I've narrowed it down. They're the people that at the end of their life, they can say the same thing. They changed not just their patients, but they actually help clinicians change patients. And that's it. That's what we're here for. We're not much more special than that. If we can do something to help one clinician, help one patient, I would say our entire existence is worth it. So I want to say to each of you, there's 67 people left, which to me is amazing. You're all amazing. Thank you very much for coming on. Thank you very much for being part of the webinar. I hope you learned something. I hope you get fired up. I hope you want to go to practice tomorrow. Have a great weekend. And on Monday, you just kill it. You order some tests, you learn, and you get fired up to do something that you haven't done before, and that we can deliver what we need to deliver. And when we can't, we find the people who can answer questions and who can, because that's what this is all about. So I am very, very thankful for Vibrant, for the people who have listened, and we hope to catch you next time.
Yes, absolutely. So thanks for your time, your generosity tonight, Dr. Brock, and we definitely look forward to the next installment. So we will be sending out a recording link within usually the next 48 hours. We'll have that to you, as well as we will be posting a link inside our education portal where you can obviously watch it to replay as many times as you want, as well as slides that you can download. And again, wait for all of the great things that we have coming out to help you with NeuralZoomer Plus resources. So I'm going to go ahead and wrap it up. So thanks everyone for attending. Have a great night. Thanks, Dr. Brock, and we'll see you again soon.